An opportunity to have a talk in this session. I'm going to start my talk on the topic of independent determinant of urinary albumin excretion. The introduction, as we have already described the diabetes, this is the conference mainly focusing on the diabetes. So with the change in lifestyle, eating habits, and environmental genetic predisposition, the population is having diabetes is emerging day by day very rapidly. Diabetes mellitus is a metabolic disease characterized by insulin deficiency or peripheral resistance resulting in hyperglycemia. Hyperglycemia has been reported with increased risks of renal insufficiency. My topic is mainly concerned with the microalbuminuria, so I'm going to focus on this microalbuminuria topic. Microalbuminuria is a hallmark for early detection of diabetic nephropathy. The progression of microalbuminuria are partly unclear, but cross-sectional study shows increased urinary albumin excretions. The objectives of my research topic is to determine the frequency of hyperuricemia, to find out the correlation between serum uric acid and degree of albumin excretion with glycated hemoglobin, to evaluate the determinants of urinary albumin excretions. This is a hospital-based cross-sectional study which has been conducted in Department of Biochemistry with collaboration of Department of Internal Medicine, Universal College of Medical Science, Bhairava, Nepal. The 100 patients was taken as a sample size in my research purpose. The duration was of 6 months. The diagnosed case of type 2 diabetes mellitus was taken for the research purpose, and the specimens not fulfilling criteria of research work, patients with T1DM, patients using uric acid lowering agents, diuretics, alcoholic beverages, gouty arthritis, leukemic patients, and impaired glucose tolerance were excluded from my research purpose. The study protocol followed some criteria which has been given by the WHO. The nephropathy was graded as follows, as shown in the slides. These are the criteria which I followed. The results obtained are discussed in this table. Here, the total patients was 100, in which 58% of the population was male, whereas 42% was female. On the basis of smoking habit, most of the population was found to be non-smokers, about 50%, and 40% of the population was past smokers, 10% was current smokers. On the basis of alcohol intake, 56% of the population was non-alcoholic, 40% past, 4% current. Likewise, 90% of the population was found to be non-vegetarian and 10% vegetarian. When we categorize on the basis of current treatment modality, most of the patients was under the insulin therapy treatment, and 40% patient was under oral hypoglycemic agent. Likewise, when we categorize the nephropathy, 62% of the patient was found to be normoalbuminuric, 28% microalbuminuric, and 10% macroalbuminuric. This pie chart shows the frequency of hyperuricemia in type 2 diabetes mellitus. The 30% of patients was found to be hyperuricemic patients. This table number 2 shows the general characteristics of biochemical variables of the patients. Table number 3 shows the general characteristics of biochemical variables in male and female. Here we can clearly see there is no any variations of the variables in male and female except the BMI. This shows the perfect matching of most of the variables between male and female. This table number 4 shows the comparison of serum uric acid level between group variables. Here, serum uric acid level is higher in patients with high urinary albumin excretion who have higher microalbuminuria comparing with the normoalbuminuric. Likewise, blood pressure, serum uric acid level is higher in patients with higher blood pressures comparing with the normal blood pressures. This is the correlation between serum uric acid concentration and other variables. Serum uric acid concentration is positively correlated with age at onset, duration of diabetes, and urinary albumin excretions. This is the table which shows the independent determinants of urinary albumin excretion. Multiple regression analysis shows that duration of diabetes, HbA1c, systolic blood pressure, and uric acid are the independent determinants of urinary albumin excretions. In conclusion, serum uric acid concentration is associated with microalbuminuria and HbA1c in patients with type 2 diabetes mellitus. Screening for microalbuminuria to prevent renal impairment and measuring HbA1c level on a regular basis for good glycemic control are important in diabetic patients. Further examination is needed to clarify the validity to extrapolate the relationship between serum uric acid concentration and the degree of urinary albumin excretion in non-diabetic patients. The references I have taken from the different journals and different papers are as this. Thank you.
Now, yet another good clinical topic. Urinary albumin is a very hot topic. Even to the tune that sometimes it is questioned whether urinary albumin is truly an indicator of nephropathic disease or not. The recent concept is that microalbuminuria is more of a risk factor for cardiovascular disease than for nephropathy. The reason is very simple. In a study, it was found that 50% of the patients who developed renal failure had no albuminuria at all, while 50% continued to have macroalbuminuria but never had any renal failure. So the session is open with these comments for your participation as well.
Do we have any questions for Sunani?
Just for the uric acid. Uric acid was, I think, kind of regarded part of the associated with the metabolic syndrome. And metabolic syndrome, one of the major component is insulin. And insulin is a trigger for cardiovascular disease. So sometimes when I see a patient with uric acid, I really don't like it because I feel that something is going on. And what I don't like is not his glucose, but the probability that he will develop cardiovascular disease. So I'm trying to lower it, but not always it works well. Only if he lose weight and decrease his insulin. You don't have any parameter of insulin here, right? You didn't do. Okay. This is what I like. It's my craziness.
But that's a good correlation. You know,
yes, of course. That's what. Otherwise.
Any other question?
No? Okay. Because I have, I did this research because the microalbumin test is really done in Nepal. In western part of this research has been conducted in western part of my country, Nepal. Because I would like to focus my physicians, my doctors over there, to do a microalbumin test to prevent from the patients which are having diabetes. Because diabetic nephropathy is common for those patients. And I think this research will be a platform and it will give a message to them as well, because the microalbumin test is very rarely done. It's quite amazing over there in that reason. That's why it will be a new findings as well.
But you are not focused on my comment. I feel it is not required.
But she did the study before you made the comment.
Yeah.
My question was, it is more of a risk factor for cardiovascular disease. So those who are undertaking research in cardiovascular disease, they should undertake microalbumin. Why? Because it is no more regarded a true risk factor for nephropathy after this research. Anyway, thank you very much. It was a very enjoying presentation.
Just
You
a
have
question
more?
about Nepal. This is a personal curiosity. When I've never been to Nepal, and for me Nepal is mountains and villagers. Is there any difference between the prevalence of diabetes in the rural and the urbanic place?
Yes,
In
of
religious
course.
countries, diabetes is found lesser.
Yeah, of course. I have recently seen the Gavali papers. Gavali, one of the researchers, he has mentioned that 8% of the population was found to be a diabetic in urban population, comparing that a rural population have lesser 1%. It is a very vast difference between urban and rural populations.
And I suppose in India it's the same thing, no?
No.
No?
India is now number 2 in the world.
No,
Number
overall,
1
yes.
is
but
China.
No. The question is there a difference in the prevalence of rural and urban?
Why not? It's about 4 times difference. It
So-
has been found in India that the rural population has 4 times lesser diabetes as compared to urban. But this gap is narrowing since the urbanization of rural population is taking such a pace that I think after a few years, might be 10 years or so, you will find the equally incidence everywhere, the prevalence everywhere, because all the villages are being uplifted. So no doubt about it. Currently, there is a difference of 4 times.
Yeah, the data just now I have presented,
Now-
this prevalence rate is of 2015, recently done, 8:1. There is a vast difference
Yes.
now. Rural people used to do many work, they have their different lifestyle, eating habits and everything else, comparing with the urban population, because they are very busy schedule, and the eating habits are very, there is a vast difference of eating habits, that's why the prevalence rate is very
Thank you very
changing.
much, Dr. Sunita.
Thank you
Now-
so much.
Since she has cut short her presentation, probably for me, because workshop was being missed. So